Hello and welcome to Learn from the Case. Today I want to awaken your curiosity with a new neurological case. I want to talk about Myasthenia gravis. Nicolina consulted her primary care doctor because she suffered from a lot of fatigue, lack of energy, and feels gradual wear and tear. But during the consultation, she breaks down in tears when answering the question about daily functions because she wants to comment that lately she has been releasing gas involuntarily. She has also had mild urinary incontinence for some time ago, which she was told was linked to the birth she had gone through. She avoids sneezing, coughing, or laughing out loud when she is in the company of someone, because those particular moments may cause her to involuntarily release urine or gas. She is ashamed of this, and the primary care doctor tells me later when he presented the case to me that he let her know that there is nothing to be ashamed of, but that is important that she mentioned it because there are possible important physical causes that can lead to poor sphincter control. Nicolina is married with 3 children, 2 twins, a functional family. She works part-time managing the mechanical workshop that has together her husband and father-in-law. Clinical evaluation and laboratory tests showed somewhat overweight by direct observation and a BMI of 27.5, fasting glucose of 6.2 and HbA1c of 48, twice measured, with no observations in hematocrit, liver, kidney, thyroid, cortisol, vitamins, glomerular sedimentation rate, rheumatological tests, etc. She also had no body pain, spontaneous pain, or pain in palpation of the fibromyalgia point. ECG showed sinus rhythm of 78 beats per time with ST segment depression in V4 to V6, R wave with somewhat elevated amplitude, and S waves in precordial slits, which indicates left ventricular hypertrophy, but it was not very marked and did not entail any difficulties verifiable in cardiac work, meaning that these findings have no relevant clinical importance for the patient's current symptoms. A visit was scheduled with a diabetes nurse to better see the diet and physical activity in order to improve blood glucose values, and also was an appointment to check 3 different times the blood pressure at different times during the coming week to see that it does not rise above 130/80 millimeters of mercury, because she has diabetes and that is the limit not to exceed for people with diabetes. It was recommended to maintain healthy routines, try to do yoga and meditation, and get active by walking or doing daily activity. This would have remained there if it weren't for the fact that the person who talked to her on the bus asked her if they had ruled out myasthenia gravis, because that person knew of a case with symptoms of extreme fatigue that ended up being myasthenia gravis. When she came to me, she had already managed to verify the diagnosis with her primary care doctor. She came for neurological evaluation and treatment. A person with myasthenia gravis might feel symptoms like weakness of arm or legs muscles, double vision, drooping eyelids, and problems with speaking, chewing, swallowing, and breathing. This condition can affect any skeletal muscle groups, including the neck or proximal limbs muscles, have a higher incidence among the female population. Nicolina was at that point 53 years old with a past medical history of type 2 diabetes and hypertension. The latter has sometimes been difficult to control. She reported neck weakness, which she described as an inability to hold the neck straight. It began without any preceding trauma, infection, or significant stressor. Neck weakness started suddenly, worsening throughout as the day progressed, causing mild pain with no notable aggravating or alleviating factors. There appear to be no diplopia, ptosis, dysphagia, dysarthria, dysphonia, regurgitation, neck stiffness, photophobia, fever, chills, or difficulty breathing. There is no significant family history of autoimmune disease except for hypothyroidism in the mother. Detailed examination revealed 3 of 5 strength of the neck musculature, but intact strength in the upper and lower extremities. Spalling and Lermitis signs were negative. No sensory impairment was noticed. Deep tendon reflex were 2 plus, symmetric all over, with Babinski negative. This thinking little on eventually degenerative joint disease, vertebral compression fractures, muscular dystrophy, neuromuscular disease, and paraneoplastic process. Colina underwent a cervical CT and blood test for inflammatory markers and metabolic panel. Everything was unremarkable. There were no signs of infection or inflammation on complete blood count and comprehensive metabolic panel. Liver function tests, including aspartate transaminase, alanine transaminase, and alkaline phosphatase, were within normal limits, excluding muscular inflammation. Autoimmune markers came out normal as well. The erythrocyte sedimentation rate was 12 millimeters after 1 hour, and the serum creatine phosphokinase levels were mildly elevated at 260 units by liter when normal is 22 to 198 units by liter. All this was after the first neurological evaluation with me. The anti-acetylcholine receptor binding antibody was 11.07 nanomoles by liter. Normal is less than 0.27 nanomoles by liter, with a measurement method called RIA or radioimmunoassay, which indicate a diagnosis of myasthenia gravis. Depending on the clinical picture and laboratory results, we decide to prescribe cholinergic agonist rather than performing electromyography to diagnose myasthenia. So Nicolina was introduced on pyridoxine, mestinon, 60 milligram therapy. And she got a follow-up appointment 3 days later. Then her symptoms improved drastically following the commencement of pyridoxine therapy. The disease was no aggressive in course. The patient is stable on the medication since then, with no recurrence of weakness, no report adverse effect of therapy. Based on the referral from her primary care doctor, I asked her for the sphincter control, and she said it was almost totally under control. She still leaks a little urine in sudden sneeze or similar situation. This might need a little bit more time or may be related to the birth she had. Myasthenia gravis is the most common neuromuscular function disorder. It's important to rule out myasthenia gravis in patients who have chronic fatigue and sphincter control problems. She even had neck weakness without classical fluctuating weakness at the neurological evaluation appointment with me. Weakness in myasthenia is due to impaired action potential propagation caused by damage to postsynaptic acetylcholine receptor, due to which muscles do not depolarize. The disease follows usually a bimodal pattern of distribution, with a peak in the second to third decades among the female population and another peak in the fourth to eighth decades among the male population. That is all I wanted to remind you today about myasthenia gravis. Still, I would like to leave with a thought that I feel has been far too far forgotten in many doctors' knowledge recently. When a patient are admitted to a hospital with acute respiratory failure without any underlying pulmonary disease or without a sufficiently severe lung condition, that can really explain the status present with the patient and with weakness of the respiratory muscles. The diagnosis of myasthenia gravis presenting with a myasthenia crisis should be considered. A myasthenic crisis as the first presentation of this condition. Think about it. Well, here I conclude this presentation of myasthenia gravis. I would love to read you in the comments if you have any experience with myasthenia gravis that you want to share. Leave them in the comments. Thank you very much for your attention. Keep researching and studying and be well. If you like this content, be sure to subscribe and follow me. See you.